around for a while. And recently there was a court case out of Australia that I put into the EMDR News site and various things. And birth trauma was one of the things that we have information on. All right, everybody. Hope that everybody's doing well out there in the world. This is Dr. V, Doc V, Dr. Vermillion, Tim Vermillion, whatever you want to call me, from EMDR News. Sorry about that. Just straighten that up a little bit. And today we're going to be talking to you about body dysmorphia disorder, BDD. So hopefully you'll stick around and we'll talk about that for a little bit. It's very interesting. We can tie in a few other things that we know about EMDR and where it works into the conversation about body dysmorphia. And I want to talk about why it's important to me. It's an interesting conversation, and it is close to me. There's a story involved, and I'm hoping that the story helps you kind of understand why I'm bringing it up at all. But first, let's get into what's happening again. So 10 days now until the conference, I believe, or actually 15 days or something, but 10 days until I travel out there. Exciting to have the conference and be there. I love doing these things. I love seeing everybody. Um, and again, if you see me, feel free and pull my you know sleeve or something. If you want to ask a question, if you want to suggest a segment, if you want to come on and be a guest. Which reminds me, I have to call Sebastian and see if he's still on for tomorrow to talk about EMDR and the homelessness situation that is accosting the veterans, right? So we're going to be talking about that along with some military sexual trauma conversation. So we'll be looking at that tomorrow. And yeah, so the conference is already out there. The early bird is done. You can't get early bird anymore for the conference. Now it's whatever it is. There should be hopefully some rooms still at the group rate there, the conference rate at the hotel, but otherwise there are plenty of hotels around. I had looked as well to see what's available. But I'll be in the main hotel, so you should see me wandering around, uh, hopefully with some purpose, not aimlessly. So it'll be a fun time. Looking forward to it again. It's one of the highlights of my year is to get to meet with everybody. So then we have the ISDSS conference, right? That's in again San Antonio. Love talking about that. Love being talking about San Antonio. And then after the ISTSS conference, we have the EMDR HAP conference, right? So those are all the things that we know are happening right now. Um, and our field signals should be updated somewhat regularly in terms of what's happening. So if you're just curious about what's going on in the EMDR world or the world at large, because sometimes I'll throw up some stuff up there that pertains to the therapy, trauma, what's happening in the world that can start to have an effect on people. Because I mean, I still have clients, and I'm sure that you do too, that come and talk about the various things that are happening and how they impress on them. There is a recent news thing. Let me see if I can pull it up real quick. Did you? There you go. Let's see here. Associated Press, right? So again, the military piece, right? So we have the Associated Press reporting on August 5th, so yesterday, that uh, um, some spouses and relatives of soldiers that are serving in the military have been swept up in immigration raids. Up to 50, it looks like, have been swept up. And so you're thinking about people, in the military, you're thinking about veterans, you're thinking about people within the context of being overseas and deployed, maybe not even hearing about this stuff because they're doing their job. And now they would have the added stress, or when they come home, the difficult stress of dealing with that as well, right? Sorry about that. I'm going to turn off notifications at some point. But yeah, so 50 parents and spouses of active duty service members detained, and for whatever reason, but for immigration purposes. So it's just an added stressor. It's an added thing. The immigration thing for a lot of people is an added stressor. It's something there, and people often are in the U.S. or in the military for the purpose of doing what they need to do, serving the country because they want to be here, right? And they're going the right way. And meanwhile, on the other hand, picking them up and sending them out, putting further stress on the people that are serving. And it's not just you, the soldier, that is going to have a difficulty with this, but if you are unable to do your job as well, because now you have to think about your parents or your spouse being sent to some place that maybe they have no experience in, um, they've been gone for years, maybe they never even kind of have an experience there, like never really lived there. Um, and now they're shift over there. Now you have to worry about that on top of watching your back and watching your buddy's back. So again, added stuff to trauma. We do have the global stuff happening as well with Ukraine, right? So it's still back and forth now. So that's pretty significant. And again, that's the APP as well, Associated Press. Um, Yeah, so there's a lot of stuff going on that is in the background of all of this, and people can definitely have an issue that is exacerbated by this stuff. Veterans, when the veterans come in, they can have exacerbated by the stuff going on in the Middle East, and feeling that now that war's starting over again up there or something like that, that the work that they did didn't mean much. And I'm saying that because that's what I've heard, literally, from them specifically. So those are a couple things that we want to kind of look at there. Let's just take a quick look. Anything else worth looking at right now? Hmm. VA technology. Okay, so just something about the VA app being updated so that you can do a little bit more on it if you're a veteran. But I was thinking when I saw that, I was thinking about another thing that somebody has approached me on, and I have to get back to them regarding virtual reality, right? A virtual reality solution that you can use for PTSD and stuff like that. So if you're out there and you have some ideas and thoughts that you want to get out or that you want to discuss, feel free and reach out to me, and I'll do my best to continue the conversation, because I do have the habit of starting the conversation, and if I'm not, I need to keep on it. That's what it comes down to. Um, yeah, so today we're going to be talking about just pulling up my notes here. We're going to be talking about the body dysmorphia. Okay, so here's the story. All right, so um, it's easy for a lot of people to kind of uh, well, I had a coach, and the coach passed away, right? And we're not sure why he passed away, but in the process of it, you hear about the culture, right, of the bodybuilding and fitness, and whether they're using SARMs or not using the SARMs, and with ages they get into this and they're working on it. And I don't know why my coach passed away. The exact results were not released, and we could assume that something nefarious was about, that. Maybe it was due to that stuff, but I don't want to say it directly, say it affirmatively, because I have no idea. But the idea again is that, he was in the fitness industry, he was young, and, he um, did what he needed to do to look the way he thought he needed to look, and also support other people, right? So thinking about that is one of the reasons why I brought this up today, right? Another is because I look for research on EMDR, and EMDR used in interesting cases, and body dysmorphia disorder was one of those cases that came up for me. So, and then my coach passed away on January 8th. I think it was January 8th of this year. So it was fairly recent. Good guy. Was working with him for a while, and yeah, and that's why stuff is hits close to home sometimes. Okay, so let's get into this. Just taking a quick look on my notes here. Mhm. So there's a lot of research on BDD, but there's a scant amount of research on BDD and um, EMDR. And the little amount of research is not great either. It's not generalizable. It just gives us a signal and says, "Hey, this might be worth looking at again." So basically, what they took was four. I think it was four, right? All of a sudden, the exact numbers popped out of my head. Four people, four females that had body distorted dysmorphia and used PTSD or used EMDR to help with them, help with their symptoms, and there was some success in that. But again, it's a very, 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 very small sample. They did not have a comparison group, so it's hard to kind of just say, yeah, this works, right? So we have signal that it works, but the jury's out on whether it'll work for your client, basically. And that's why research and randomized control trials are so important, and pushing it is because we don't want to take a spark and it's something that could have happened or could have happened because it's just a small group, and extrapolate that idea and say, yeah, everybody's got that same issue. um, so we can go into BDD and why it might work and what might EMDR help with. So that's what we're going to get into a little bit. Let me just take a look. Just wanted to make sure on this piece here. Okay, I think we're good with that. All right, good stuff. I want to make sure that we're answering questions today if questions come up, because this is an interesting topic and it's an important topic because 2%, 1.5 to 2% of people end up with body dysmorphia disorder, BDD. It is in the DSM. It is a disorder, and it's not like swept up into eating disorders. There are separate disorders. You can have comorbidity. You can have both, right? But it's not the same as what it comes down to. They are not equal. One can be treated without the other. So let's I'm jumping around a little bit as I talk to you today, because I again want to make sure that I get to any questions, because this is a good one in my opinion. Um, so let me check this out. It's not showing here. Let me see. I'm seeing that the live may not be showing on LinkedIn. How can I fix that for you? So yeah, 2%, and that goes. It's both sides, right? Male and female. They're both. There's no real difference between the rates of each. They might show differently in terms of how people are demonstrating, or how you can tell that they have this issue, but at the same time, it's not the same there. Rather, that it is the same. The statistic is the same. All right. Well, I can't see why this isn't showing, so I might just have to leave it be for now. Got to fix these things every now and then, but I am on Facebook, so that's good. We can go from there. Let's pop back in here. Get back to the screen over here. All right, we are back. All right. So yeah, 2% is a pretty big number when you think about it. It's not a unheard of. It's not rare to have body dysmorphia disorder, and it can show itself up in different ways. It usually starts when you're a teenager, in adolescence, and can stick with you for a while. Sometimes it shows up in shame and embarrassment. Looking at how you look in comparison to other people, and comparison to yourself sometimes. Um, there's some behaviors that go along with it that people are, when you're doing this work, are kind of trained, or trying not to do those behaviors, right? Like in vivo practice for the behavior is like not checking the mirror, not asking for validation when you're in a social setting, right? These are some of the things that you might see somebody that with BDD constantly doing, right? And it increases their anxiety. It pushes the whole BDD thing along. Um, which is why cognitive behavioral therapy is the gold standard therapy, along with ERP, as well as a good one, and SSRIs, right? Those are like the three things that are right now are research to say, hey, this is what we're supposed to do. But again, circumstances, alter cases, and not, what one cookie cutter doesn't fit every cookie, or something. You get what I'm trying to say. So with that in mind, that's an issue, right? That we have to sometimes figure out how we can help people that aren't being helped by the gold standard. When we think about research and stuff, uh, generalizability and having it say, yes, this is evidence based, it doesn't take too much to do that over the placebo effect. It has to be generally retestable to show that it is better than a placebo, right? Better than waitlist. However, how much better is a different question entirely. So it could be 60, 70, 80%, maybe, it could be 100% better if you're really, 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 really lucky. Very rare. But yeah, so CBT doesn't necessarily work for everybody. Nothing does. So EMDR might be an option. And right now we know what we can do with EMDR in general, right? Just like bipolar illness or something else where we can't necessarily treat the specific injury or illness itself. Right. What we can do is work on those things that surround it. The memories of being bullied, of being harassed, of being um, otherwise treated inappropriately or uncomfortably, I guess, when you're dealing with body dysmorphia, when something's amiss. And so they do their best as they to change their appearance and to look a certain way so they don't carry that anxiety with them. So with ERP, which is an exposure piece, um, they go out, they do not do those things, those behaviors that they're supposed to, that they are accustomed to. Again, looking in the mirrors, checking for validation from other people. They struggle to do that. That's some of the in vivo type stuff that they try to do. Like, don't do that. So it's pretty. It has that exposure component, and sometimes when they talk about EMDR doesn't necessarily have an exposure component, and I challenge that because when we look at the phobia work, right? There is an exposure component, and I believe it's right in the book, right? That Dr. Francine Shapiro's book on what that would look like, those exposure pieces. She doesn't specifically, I don't think, if I remember correctly, give you specific guidelines on like a whole piece of going out and what you do or anything like that. But they are encouraged to go and practice or go out there and deal with the phobia piece, and then you come back and you work on what happened. Right? It's kind of like a present trigger, future template, future rehearsal type deal. So with with BDD, we can probably consider the same, right? We can imagine having EMDR being using a modified version or a version of the phobia protocol to do something like this, right? So we do have memories, though. We do have the memories of the bullying. We have memories of being harassed. We have memories of otherwise being treated in a way because of their appearance, their weight. How many of you know somebody whose parents, when they were young, or maybe even now, look at them sideways if they gained weight? Usually a female, not always, but usually a female, right? And they are, or even as a young person with what we call maybe like baby fat, haven't grown into their bodies yet. They're starting to get fat shamed, right? Um, so another piece of this, right, is what you do with it, right? So I've already mentioned the gym. So you might start the gym because you might be overdoing the gym because of this, right? I have to look a certain way, right? If I don't get to the gym, then I'm failing myself and my body. It could end up being comorbid with an eating disorder, right? Because again, my body doesn't look right, and I have to look right, and so, right, you get into these loops of how this works. So these places and these areas, we can definitely intervene. We can definitely step in, and EMDR can help with a lot of this stuff. Um, we can work on uh, the addiction piece, right? So again, with uh, steroids, right? It's not necessarily the same type of addiction. It's not like a crack, a heroin addiction, but when people are reaching for gains, using some gym jargon, right? Do you even lift, bro? When people are reaching for gains, then they might feel they have to use this, and it might be true actually, depending on what they're trying to do, because a human body doesn't look like that without some help. So they're looking for or seeking a specific body size, body type, and they don't get it and they don't see it. And you'll be surprised because people have a goal, right? In the gym, and they reach that goal, but that goal starts moving away. So that's kind of like how people get into some of this body dysmorphia in the gym, is that you're never happy with your body. And that's for a lot of people, right? And that's how that happens. And a lot of people will start out just saying, I want to get into shape, right? And then it'll be, well, I want to be fit, but be natural, right? And then they'll slide into like, okay, I'm not going to get that body that I want now because I'm in the gym all the time. I see these people, I'm comparing myself, and I'm not them, and I don't look good as them, and I'm not as big as them, and I'm not, and then all of a sudden you're going to be possibly adding to it. And this is body dysmorphia. I mean, there might be other reasons to do steroids, might be other reasons to do other performance enhancement drugs, SARMs, etc. But in the end, um, we're just talking about body dysmorphia disorder today. And we can go. So that's that piece, right? The gym piece. People can overwork themselves. People can start taking SARMs. People can have all of these things, and we can intervene in the addiction piece, right? And we can use like a feeling state protocol in terms of helping people take that piece. What does it mean to you to look like this? And I think that's a big piece of why EMDR might work well for body dysmorphia disorder, not just for that small sample and that one study, but for other people as well, is because we have that ability to kind of understand and work with not just the trauma memories and these memories that push right? Push people into trying to find some way to manage their discomfort with themselves, other people in the world, right? And that would be, again, people that push into that is trauma, right? Like, I don't want to be harassed. I don't want to be bullied. I don't want to feel this way. And so that stuff is fuel for them to search for ways to assist in trying to deal with their body dysmorphia in a maladaptive way. And then you have the pull, right? So what happens when you do get this stuff, right? Although you might not believe it when somebody says, wow, you look good, right? Body dysmorphia is sometimes like, that's just a trigger saying, well, no, I still have so much more work to do, right? Or even more possible is saying that I have so much more work to do, or I um, or maybe they're just saying that, or they're lying, or something along those lines. But when we look at overweight stuff too, and the new GLP craze, the GLP-1s, that's another issue, right? So what are we doing with GLP-1? Again, it's perfectly fine if it's within the context of a medical discussion. The VA is even considering using it for alcohol at this point, right? So there might be some benefit for GLP-1s, not just with diabetes, which is, I believe, what it firstly started with, but now fat loss, right, which is now the big thing. And now they're using it, now they're possibly using it for alcohol addiction or alcoholism. Pretty interesting stuff, right? And who knows where will this take us? We get a panacea for everything. Take a pill and eat what you want, right? I'm being sarcastic on some level. So um, we want to make sure that when they're doing that, right, it's not in response to shame, or totally in response to shame, or other, feelings of uh, um, self confidence issues. We're trying not to do that. So we want to pay attention to that piece, right? It is a good tool, but we want to make sure that we're using it for the right reasons. What else can I say? That let me look over here and look at my notes again. I think I got most of the stuff that I wanted to talk about it. So, it's a valuable adjunctive tool to, it could be a valuable adjunctive tool for BDD, but right now especially with comorbid PTSD, like, why are you doing this? That push, with that stuff, it could be helpful. But right now, it's not suggested as a standalone intervention because there's no research on it. The most clinically sound approach right now, again, is the cognitive behavioral therapy for BDD and the exposure program, the exposure response procedures programs, perceptual retraining. Let's see here. Anything else on here? Preliminary again. There was a study of 4 people, again, 90-minute sessions and a 3-month follow-up. Right, no control study and not randomized, not just a signal. Not very helpful. It's like if you wanted to pull out 4 people that you were working with and send in what happened with working with them, right? That would be a signal like, huh, this is interesting, but we would still need more research to actually have anything that is specific. SSRIs are also suggested for this, especially for severe impairment. All right, we can check one more spot. There we go. They do have the safety issues because we are dealing with something that could also be comorbid with depression and suicidality, right? So when you do have body dysmorphia, it could be something that you're continually struggling with, and if you can't get on top of it, or if it continues to beat you down, suicidality is a big possibility that could be a possible there. It is different than OCD. It's different than eating disorder. They all have their own stuff. Different than dissociation. We still want to map trauma history for EMDR purposes. That always helps. Adjunctive EMDR, again, we want to see if there's comorbid PTSD dealing with the push, the maladaptively stored memories that might be stimulating the behavior of BDD. So target selection could be the earliest and then the worst, and then any interceding stuff. There might be some abuse or body shame memories that we want to work on. And then we want to monitor for ritual substitution or distress spikes, right? So we can use them in parallel, but not alone. So here's a good one, another important statistic though. When we look at BDD and suicidality, there's an 80% rate of ideation, not that they tried or anything, but ideation. And there's a 24 to 28% of actual suicide attempts within the BDD population, the body dysmorphia disorder population. So the relative risk is 3.63 for suicidality versus the general population. And a good important note is that if you're going to do EMDR on trauma work and they're already disturbed in this way, where they have suicidal ideation and they're really depressed, we want to make sure that we are doing our safety planning and making sure that we are attending to what's happening with those clients, because trauma memory work can be highly distressing and can just add to that ideation, possibly. So again, we always go back to readiness, right? Do they meet readiness criteria? And so this question and exploration of suicidality is that thing that we're going to be looking at to see if they do meet a part of what we're looking at to see if they do meet readiness criteria. Okay. So yeah, EMDR is a valuable adjunctive role within BDD. Especially for those things with comorbid PTSD. But CBT for BDD is currently still the best thing that we have and is our clinical go-to, right? That kind of thing. All right, so I would support with these things in mind that we want to work on this stuff. So if we're going to use EMDR on body dysmorphia disorder, we are going to first recognize that it's not a first-line treatment. The first-line treatment is CBD, BDD, right, for borderline or for body dysmorphia disorder. Okay, so let's try that again. So we can treat border we can treat body dysmorphia disorder with EMDR, usually as an adjunctive. The primary treatment for body dysmorphia disorder is um, cognitive behavioral therapy for body dysmorphia disorder. There's also an exposure piece and sertraline, or not sertraline, but SSRIs that can be helpful and are part of that treatment protocol. That is for the standard at the moment. It is important because 2% of the population do have body dysmorphia disorder, and that is across both male and female genders. Um, we can use EMDR on PTSD related memories if there's comorbid PTSD, or we can probably focus and look at all memories that are big T's or little T's that have to do with abuse, body shaming, and the things that have happened in the process of socialization. You know, what if there's some bullying or anything like that that has happened. So all of those memories we can work on. We might have to work on other memories as time goes on because of what the body dysmorphia disorder can lead to. So if you are doing fad diets, if you're doing extreme workouts, if you're taking certain other medications, if you're doing all of these things and in the process there's some type of little t or big T trauma that happens, then there's still work for us to do. I suggest that we also consider the phobia type protocol, not for the phobia per se, but the way that it works so that we can do some of the EMDR exposure piece as well. And the Miller feeling state protocol can be really helpful, in my opinion, in terms of working on this, the pull, what it means to you, right? Um, so yes, I would suggest that we can use BDD, again, within the limits of our scope of practice, and recognizing that it is not the first line treatment, and also recognizing that there's a lot of research that still needs to be done. But yes, you can start with your case studies now and get that research done for us. I use EMDR a lot. I consider myself an EMDR therapist, and I generally have success, and not all the time, but generally have success. So with this, I can imagine a context with it working. And again, the same thing that I tell my colleagues when they say, hey, is anybody working in addictions or anybody working in compulsions, rather, like gambling? And I say, well, I'm not a expert. But if there's nothing else, right, if there's no other resources, I do work with that population, and I do generally have good results, right? I don't have any certificate in it or anything like that. But when I do it so much and I enjoy it so much, and it's an experience thing at that point where I can say, yes, I can do EMDR on some of these things and have good results, right? So um, let's go out there and let's get our body dysmorphia disorder people in, do a good assessment, see if they would be helped by CBT, or again, the gold standard for that issue, or if they'd be helped with working through EMDR, or maybe doing both in tandem, in parallel. All right, so that's going to be all that I'm going to say about that. So right now, just kind of closing up, feel free, reach out, let me know if you have any questions, concerns, issues, ideas about things that you want to work on in the future. I believe that I put up our schedule just a couple of moments ago. Let me see if that's still up there. Well, we got something in there, but I don't know if that's what I wanted. Let me see if I can pull it up again. And while I do that, just a reminder that I'm trying to do this at 9:30 each morning. It might actually move to 9 to 10 instead of 9:30 to 10:30. And that's just because of some other work stuff that I'm trying to organize. I'm a team lead, so I have to kind of get some of my admin stuff done. And I just moved into that position, so I need to give myself time to do that. So I'm trying to maneuver my schedule around that piece. So come on. Just one more minute. First you don't succeed, just quit, right? So let me go ahead and move back and just throw up the one that I saw a second ago. It's weird. So here it is, but it's kind of like a 7-second thing here. Still learning how to use this thing up here, but doing my best. And I have some fun stuff that I've been playing with. And maybe this will work. There we go. So if I put this up there, you might be able to kind of just kind of see what there is, and it's going to loop. So there you go. So we have preparation and positive event timeline. So I've been talking a little bit about positive event timeline already, but now I'm going to be adding to the positive event timeline more preparation stuff. So we're just going to go into preparation because I believe that preparation is one of the underutilized pieces and misunderstood. Right? What is it for? So we're going to really dig into that again. And 11th is smoking and harm reduction. Again, harm reduction, especially where it comes to smoking, is an important piece of what I do in my day to day. It's something that I advocate for, harm reduction. As a matter of fact, in November, the Partnership for Drug-Free New Jersey just reached out to me and like, hey, can you send in your details because, we wanted to get them in so that we can get the CEU started in November. I believe either the 10th or the 11th or around that time, I'll be doing a webinar for them on opiates and veterans. Again, I'm a harm reduction guy, so that's what I'll be talking about. I did this a year and a half ago, and apparently it went well. So hopefully that we can continue that, continue that, and this will go well as well. We have the neuroscience of EMDR update. So I'm working on that, and I'm hoping that that'll be ready for you by then. But a lot of the neuroscience stuff that we have right now, like Alan Shore and all of that, there's been some changes in how we look at things from the medical population, right? The doctors, neurologists that are out there. And so some of the ideas about hemispheric work and all that stuff are not widely accepted. So we're going to take a look at that because even in common parlance with EMDR, people still use a lot of the hemisphere speak, like right brain to right brain, all of that. So we kind of look at that a little bit differently, put another lens on to see what that's about. Okay, let me take this off and sort of hopefully not giving everybody any issues over there. So we'll talk about the neuroscience of the EMDR and some attachment issues and stuff like that when we talk about that day. And then what was the other one? We have attachment focus is the next day, so we'll talk more about attachment on the 13th. And then Friday is mental health in the military. And the reason why I have mental health in the military is because a lot of people, when they think about the military, I've in regards to social issues like the transgendered population being excluded or trying to be excluded by the military by the current administration. People are like, oh, we need a certain level of mental health and all of that, and so a good a little exploration of military mental health might be interesting. And as you may or may not know, that's part of what I do, right? Or what I've done anyway, is military mental health. So I'll touch on that a little bit. And one of the things that I'll give you right now is that a good percent of the population of the military is on medication. They get deployed with medication, and it's okay, right? And some of the medications are pretty pretty significant. So when we say that we don't want people with a certain level of mental health issues within the military, we're promoting stigma, but we're also not paying attention to the facts, right? Not paying attention to the idea that, hey, this is the situation and the status, and people are able to function well with mental health concerns, even while medicated within the context of their military service. So we'll be exploring that a little bit. Good times. So tomorrow, wear red. Gonna figure out something to wear. than my usual. But yeah, wear red, and I will see you tomorrow to talk about military sexual trauma and military veteran homelessness. Thank you, everybody, for coming, and I appreciate you, and I appreciate you being in the audience. And if anything comes up, feel free and let me know. This has been Doc V, keeping above the signal, keeping above the noise, and approaching the signal. Have a good one. Thank you.